Hello, and welcome to Timing is Everything, a program of Care Dimensions. My name is Mary Crow, Director of Professional and Community Education at Care Dimensions. We continue with our series of programs for you around Hospice, a journey of care through the lens of the interdisciplinary hospice team. Today our topic is A Day in the Life of a Hospice Nurse. We have a pleasure of speaking with two of our wonderful nurses, Abbie O'Grady, who's the Director of Quality and Patient Experience, and Paula Marques, who is one of our LPNs. Welcome to the show, Paula and Abbie. Great to have you here. So why don't you start by telling the audience a little bit about yourself. Abbie, we'll start with you.
Sure. I'm Abbie O'Grady. I've been a nurse for 18 years, and I've been at Care Dimensions for almost 13. I started as a nurse case manager, which I did for several years before moving into clinical management, and now director of quality.
That's great.
And
Paula
Marques.
Yeah.
I've been a nurse for 43 years.
Wow.
Been with Care Dimensions for 23 of those. I've done various scenes at Care Dimensions, home care, long-term, and assisted living, which is where I am now. But yeah, it's been great.
That is amazing, huh? Wow. So over half your career
Yes.
doing this. That's wonderful.
Yes.
Excellent. Both of you, really, right? That is excellent. So, and it leads me into that you were talking to, and we'll talk about that too, Paula, about when you were saying different settings, because people think that hospice is just in one spot. But we'll
Exactly.
talk about that too in terms of the different settings that can be provided. But I wanted to ask you both, and I'll start with you, Abbie, again. What drew you to hospice, and what makes this work so special?
So I started my career working in the hospital setting, and the majority of patients that I was working with were facing life-limiting illnesses in some way. Many were end-stage respiratory disease or end-stage renal disease. And I found that I was having goals of care conversations with most of my patients and with their families. And I found that work to be enormously meaningful, to help families get kind of beyond the fear and the taboo of talking about those things, and really to be able to just all sit down as a team and figure out what patients really wanted. It was so rewarding, and the more time I spent doing it, the more I started saying to myself, I really need to go to hospice. And when I finally did, it was like I had come home.
Wow.
Yeah.
That's wonderful. I want to just pick up on something that you're talking about, because you're talking about goals of care, and sometimes for people out in the audience, they might not understand what that means, but these are so important, these goals of care. What are people's wishes, right? And these conversations are not easy to have.
They're not.
Yeah.
And it's beyond just, do you want to be resuscitated? I tell that to people all the time. It's not just, do I want CPR, but how do I want things, right? Do I want to be treated for infections? Whatever it is, how do I want my care, my health care to go? And it can be scary, and people don't know that it's okay to talk about and, hold each other's hands and kind of get through it. It's not as scary as people think.
Well, and this is there's a shift though in healthcare, hasn't there been? Because we used to kind of put that all on the healthcare team of they're making the decisions on our behalf, but that's not what's happening now. It's really important that people have a voice in terms of what their wishes are and how the care is being provided, because everything should really revolve around them, shouldn't it?
Absolutely.
Yeah, that's great.
Exactly.
And like I said, this is a skill set to have these conversations, and I don't think people realize that. And I think that's one of the things I love so much about hospice and palliative care, because there's so much expertise in these types of conversations around death and dying, around goals of care, all of that. Yeah, so Paula, how about you?
Well, I was working in long-term care, and one of our most favorite nurses, Mary Patchett, was the nurse who came to the facility that I worked at, and I was always just in awe of the way she was with the patients that she took care of. And I used to find that I'd look forward to her coming in and then being there when she did her magic with our patients.
Yeah.
And I just fell in love with what she was doing, and I felt that that's something that I want to do, because she was just able to give so much one-on-one time with somebody, you know, and just make sure that they were comfortable and they had what they needed, and she was comforting with families, and and when you're in long-term care, I mean, it's always go, 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 you know?
Yes,
But this was like a slowed down pace and lots of attention for somebody.
Yeah, so she really modeled that behavior for
She
you
really
of what this is all about and what this
Yes.
can really be.
Yeah.
That's wonderful. I hope she knows that. I'm sure
Oh,
she does.
she's one of my favorites. She knows it.
Yeah. So walk us through a typical day. What's a typical day for a hospice nurse, as if there's any such thing?
Right.
But give us some idea of that.
Okay, so first thing in the morning, we kind of look at notes that come in from the night before, any emails or anything, and check in on what's going on with somebody. I do assisted living facilities now, so I work with. I'm a float for the team, so I work with a bunch of different nurses. I help out wherever I'm needed on that particular day. So I try to look at all the emails and really focus on what's going on. But then we find out, okay, this person needs a visit earlier than this one, so kind of arrange my schedule that way. Make contact with the case manager, just to say, this is what's happening today, this is where I'm going to be, is there anything you need me to do? If there's situations with, the social worker may be of help, I'll contact them, or the chaplain if someone's doing poorly and I think they might need some spiritual support. So yeah, it's we kind of just all kind of get together and figure out what's going on with that patient for the day.
So the whole theme of this whole series, right, is the interdisciplinary team, and it's just what you're talking about.
Yes, absolutely.
So let me go back to a couple of things that you're bringing up. One is that you're talking about different settings. A lot of times people think, okay, I agree to hospice, I have to go somewhere. No.
Home is home.
Home is home, exactly. So hospice is provided anywhere that person calls home.
Absolutely.
So whether it be their own private home, assisted living, skilled nursing facility, group home, homeless shelter, you name it.
Yep.
Home is home. So that's one thing I do like people to understand about this, because again, I really think people have a misunderstanding, like they have to leave their home. And we want to bring it to you. If that's where you want to be, that's what we try to do, right? Every step of the way. The other thing that you brought up again is, how important is this interdisciplinary team? Right?
Oh my gosh.
Talk about it a little bit more, Abbie, because again, this is the whole focus of this, because we can't do this without each other.
No, and hospice is caring for the whole patient, not just the medical needs or the nursing needs. We're caring for everything. And all of those symptoms and needs and goals and wants overlap, right? So I might be coming in to assess pain, but come to find out it's really spiritual pain or it's really emotional pain, and we need to keep the other team members involved in that and taking care of them as well. So our collaboration and work together is critical to caring well for our patients.
Yeah. And I'm glad you use it, because when people hear that word pain, they're often thinking about the physical. So much more than that. And when I was doing direct patient care, some of the most intense pain that I had ever witnessed was actually more of the emotional and the spiritual. So important that we're all working as one to make sure that we deal with that whole person. Yeah, excellent. Talk about a little bit about, patient symptoms. How do you assess patient symptoms? How do you develop that plan of care? Who wants to start with that?
You want to start?
Sure.
Okay.
Go ahead.
So I'm going to walk in to visit with a patient. The first time I see them, I'm going to review the admission notes. If I'm in a facility, I'm going to talk with the staff. If it's a home visit, I'm going to talk with the family that's present. See what their pain has been like, see what they're taking for pain, if they have other symptoms, shortness of breath, nausea, or whatnot. Just get a general idea of what they need at that time.
And pain, and we're saying symptoms too, right? Because people, again, they focus so much that it's always on pain. There's so many other symptoms people can be experiencing that can be of distress.
Absolutely.
Things like, and let's give some examples of that. So whether it be shortness of breath.
Shortness of breath, nausea, difficulty sleeping at night, agitation, anxiety.
Fatigue
Yeah.
during
Fatigue,
the day,
yeah.
decreased appetite, all of those things that might seem normal at end of
Yeah.
life can be really distressing to someone, and we want to take care of all of that.
Yeah. And you know, that it's a great point, Abbie, because really, you know, when people think of hospice, and we try to dispel this all the time, they often think of death and dying, but really hospice is about how do we help people live fully for whatever time they have left.
Yeah.
That's what you're talking about, both of you, right? As if we're looking at that whole situation, the person, how do we maximize? How do we maximize that quality? And only we do that by looking at the things that you guys are suggesting. Yeah, that's excellent. Do you have other things that you wanted to say about that, or?
Well, you had asked about the care plan
Yeah,
and the individualized care plan. So when we go in and assess the patient and find out, you know, the clinical piece of things and what are the symptoms and all of that, then it's about talking with the patient and the family and what do they want for those symptoms, right? And using our expertise to find interventions to help that meet the goals that they have. So it's aligning our knowledge and expertise with what the patient wants and what's realistic for them, and then helping to educate on that. So it's really focusing in on that patient specifically and making sure that, and then being able to pass that on to the team. So I don't want to just know for me what I can do for this patient, but I want to make sure anybody that goes in to take care of them also knows about what's good for them.
Absolutely. And it's because, you know, oftentimes we think there's this like cookie cutter approach that it's just, this is so personalized, this is so individualized, isn't it?
Definitely.
Yeah, because, and again, how do we know what is important to that person unless we ask them, right? So sometimes it's hard because we're human and to put our own views or values or beliefs on that, but that's not what it's about, is it?
No, it's all about them.
Yeah.
I always say they're driving the boat here.
That's right.
You know?
Yeah. It's interesting because when I ask people who's on the team, a lot of times people are saying, you know, when I ask patients, families, all of that, community members, they always talk about the medical team.
The patient and the family.
The patient and the families are driving the bus, aren't they? Yeah, absolutely. So talk about just some of the common challenges that you face out there, you know, when you're providing care to an individual or the family, and despite the setting. You know, it could be in any setting you can experience certain challenges. Talk about some of those.
Fear of medication.
Yeah.
That's probably one of the big ones.
Yeah.
You know, because they all associate morphine with death. You know, when you're going to give the last dose, that kind of thing. And there's always going to be a last dose, but, you know, it's all about them being comfortable, you know.
Yeah.
There's lots of medications that we use that we really need to educate people about because they just don't know them.
And we do a lot of education around that too, is that is the motto to hospice is to start low, go slow. We don't use excessive medication. It's really about what that person needs. It's individualized there
Very
too.
individualized.
Some people are not even utilizing medications, right? Talk about that, Abbie, because again, people get this thing in their head and they think about these medications. The studies are showing that hospice actually does nothing to hasten death. So, but talk about this, because this is important, because people fear this, and it's a total misconception.
Absolutely, and I'd say that's one of the biggest challenges are those myths, right? And that hospice is going to come in and immediately start morphine. And yes, we're going to want to make it available in a crisis if you need it, but we're not going to start it if you don't need it. I actually just had this conversation with someone who was admitted to hospice and asked, a family member asked, did you stop all their medications? And no, of course not, right? Because exactly what you said before, it's about maintaining for as long as we can, right? And not just coming in and saying, okay, that's it. And people don't necessarily realize that. And when the symptoms start, then it's conversations again. Are we ready to start these medications? If so, what's the best dose? And often it's really tiny what you might give to a pediatric patient even, right? Safe doses, but particularly now with the media and all of the concern about different medications that are in the news and stuff, people have that misconception that we're giving the same amounts or the same, and it's not the same.
No, not at all. Yeah. It's and yeah, I think again that we're going to have to keep educating people on this, because people just are going to have this misconception. There are studies that show that people on hospice care actually live longer, and two of the main reasons are that their pain and symptoms are well managed, and also that extra support. So I think again it's important that we keep doing that. That letting people know that that's not there's nothing that hospice does to hasten a person's death whatsoever. And again, so the more we help with people with these misconceptions, I think we can alleviate some of those fears.
And we're always trying to find interventions that are not medication, that are non-pharmacological, right? What can work for your anxiety that might not be a benzodiazepine, right? And we do that all the time. The same thing for pain. And again, it's that individual care plan. I mean, I remember we had a patient, Paula and I were paired in the field, and we had a patient with severe anxiety and pain and agitation, and she loved listening to a specific priest pray. So it was in her care plan, right? So if you were coming in, to please put Padre Pio on, right?
Exactly.
And so she could hear that and she would calm down. So we're always looking for things like that, which again is why the caregiver and the patient is so important, because we're not going to know what those things are. So, so tell us.
Yes. Talk a little bit about, because I think it is important that people know, because that is the first thing that's looked at is the non-pharmacologic interventions. What are some others? You talked about music, and things like that, but there's a lot of them.
I mean, you could come up with things for anything. A lot of times anxiety can be alleviated by quiet music, or being put in a peaceful area. Agitation can be, a lot of people like to flip through photographs, or everybody's different on what helps to calm them,
so
or helps
like
to
distractionary techniques or things like that. But even hold and kill cold, hot, heat, or whatever. Right? So there's so many different things.
There's so many.
It's, and like I said, it's important that people understand those things too, because and I do want to go back to what you said, Abbie. There is that misconception that when people go on hospice that people come off of their meds. Just talk a little bit more about that, because that's not true at all.
Not at all. And if medications are working to help symptoms or to keep the disease progression, maintained, then we keep those things. Of course, hospice is constantly looking at, are these medications still appropriate? Are they still beneficial? I think we've all known folks that are on 20, 30 different medications a day, and some of them may not be needed, and we might start talking about, is it time to stop this particular, I think of people that are on 17 different vitamins, right? That may not be beneficial anymore and could just be causing nausea or more distress. But it's a conversation, and we don't just come in, we want people to stay on their cardiac meds, or we want them to stay on their, diuretics and things like that, because we don't want you to be symptomatic.
Right. So it's when things become more distressing than helpful is when those conversations happen. I think it's important that people know that, because like I said, it's something that comes up a lot, and not something that's true. So how about, how do you go about educating families? Because the family is a big piece of this, you already said. Talk about that on when a person's being provided care, if it's in the home setting or what have you, how do you help in terms of educating the loved ones?
You have to be really good at reading your patients and families and understanding, even if you need to ask, how do you best learn, right? Are you someone that needs something written down? Is it better for me to explain it to you? Do you need me to show you? And really putting aside the medical jargon and start talking to them as a human in easy to understand information, if that's what they want. Sometimes I've been known to do it. Please give me the medical jargon, right? Because I'm a nurse and I'll understand it better. But taking that step back and talking to them honestly, truthfully, in the language that they can understand, being ready to repeat it often, because even though we all want to say, I'm hearing you and I'm listening, especially in hospice, when you're dealing with stress and you're feeling overwhelmed, it can be very hard to retain what's being told to you. So having that consistent, bringing it up, talking about it again, explaining it again, making sure all of the team members are doing the same thing can help folks to understand. But I always think demonstration is wonderful, right? Because you're hearing it and you're seeing it, and then if you can have them do it with you,
Yeah.
it's even better.
Yeah, absolutely. Yeah. It can be so scary. I always talk to them about that. We're coming into this, and we've been doing this a long time. Look at the years that you have between both of you,
right?
and how long you've been doing this type of work, and you become very competent at what you're doing. But what I remind people is that we're coming into this patient and this family at one of the worst times of their life, and so we don't bring that in with us. That we know everything. It's how do we really assess what is necessary at that point. So I think it can be tricky sometimes, and we assume that we can say it once and people are going to grasp it. No, this is such an emotional time, isn't it?
It really is. It really is.
So when you're doing this over and over and repeating, I think this is so helpful. It can get complicated too when you have multiple family members in there too, right? So
It really can.
Yeah. So how do you navigate that? It's a tricky one, isn't it?
We have a lot of resources at our hands,
Yes.
though. I think sometimes the best thing to do, it's ideal to be able to talk to everybody at the same time if you can.
Yep.
Technology's helped with that, right?
Yeah.
We can use things like Zoom or
Yeah.
conference calls or
Yeah.
however to connect with everybody. Having joint visits, bringing the social worker and or the chaplain so that it's not just one person, we can help as well. It can be difficult if families are not all on the same page,
Right.
too. And maybe, being able to do some one-on-one
Yes.
so that we're addressing that individual
Yep.
person's needs,
Yeah.
too.
And part of that is just understanding that everybody has different needs, right? And that willingness to not just treat everybody as one group, and that you can grow up in the same household and have a different childhood, and how we combat or what our coping is around illness and all of that is different. So I think it's again very much personalized, individualized again, isn't it?
It is.
Yeah.
And again, hospice isn't just taking care of the patient. We're taking care of the patient and the caregivers.
Yeah.
So that same individualization that we're giving to the patients, we're giving to the caregivers and the family members too.
I think that's like another one of the greatest things about hospice care, that it's really about the whole system, right? And we often say the word family and people think, oh, but they're not related. That family is anybody you say that person is. So whoever loves and supports you is going to be in that group, and hospice is available for all. And I think that's a big piece of this as well.
Definitely.
Yeah. So talk about, we only have a few minutes left, and so I want each of you to just think about what would you like, in leaving today, what do you want people to understand? What do you, about hospice or death, dying, what is it that you want to make sure that the audience hears today, or that what you can impart to them? Go ahead, Ab, you can start.
I have a few things.
Say them, you have
I
time.
wish we could, but we don't move in.
Yeah,
We can't bring our suitcase. It's okay to talk about, even if it's sad. I think it's really important for people to know these are conversations that are okay to have. It's okay to be sad. It's okay to talk about it. It's important to talk about it.
Yeah.
And we want to help.
Yeah.
Right. We want to make this as
Yeah.
less overwhelming, as distress less as possible for people. And that's really it.
Well, and just going back to your first point on that we don't move in, some people do. They'll say, "Well, here's your room,"
right.
and I think that would be very reassuring for people. But just people understand that hospice is intermittent care that's available 24/7.
Correct.
Right. So it's really important that people understand that, because sometimes they do think that it's live-in care. It's available 24/7, but it's intermittent care. So that, that's where the family system becomes so much a part of this team.
And our teaching becomes critical.
Yeah, yeah, very much so. How about you, Paula?
Just that hospice doesn't mean that the end is right there.
Yeah.
I had a friend whose mother actually was on service with us years ago, and her dad was very dead set against hospice. Don't even say the word in front of her, but I mean, her mother really needed it. And it was the last few days of her life that he agreed to sign her on. And at her service, days later, he came up to me and he said, I can't even begin to tell you how wrong I was. He said, you people were wonderful. He said, I only wish that I had signed her on sooner. He said, I always thought it was like, you know, you came in and that was it, she was gone.
Yeah.
He said, and I realized now that, you know, she would have had a better quality.
Yeah, and I think that is important for people to understand, and we talk about that a lot. You know, people think that it's really for the last days or weeks of life. People can be on hospice for really a long period of time, as long as they're meeting criteria.
Right.
Yeah.
And we hear so often, I wish I had done this sooner. Right? And the sooner the sooner you do it, the more meaningful the relationships can be, the more we can get to know you, and the better we can help you.
And there's a lot to do at this precious stage of life, right, that we call end of life. There's so much really healing and growth that can happen at this time, and you need more time to be able to incorporate that interdisciplinary team and get them involved to address the spirit, mind, and body. So I really encourage people to try to do that sooner, so that it's not just crisis intervention, because that's what it can be. We would still be there for them, but hopefully they can do that sooner. Yeah. I can't thank you both enough for being on the show today. This has been, I think this is really helpful for people to understand this. I want to thank everybody for tuning into this show today and continuing to watch this series around the interdisciplinary team, and look forward to you tuning into future programs.
We don't focus on dying or how long they have left. We focus on whatever they want to do, whatever they can do, making sure that we can help them along.
Hospice care is really not just the physical care, but it's also the emotional and spiritual care as well. And we try to ease people into and through the process to hopefully make it as special and as meaningful a time for them as it can be.
It can be something much bigger than those final moments with someone. It can really help prepare the patient and family for eventual end of life. And I love that about it.